So good afternoon everyone. We today have with us Dr. Abdul Ansari, Director Critical Care, Nanavati Max Super Specialty Hospital, Mumbai. So welcome you, sir.
Hi,
Uh,
Gurun.
sir, the first question is regarding personalized dosing strategies of polymyxin B. So given the narrow therapeutic index of polymyxins, what are the most reliable methods for individualizing dosing in critical care patients? And how can therapeutic drug monitoring be implemented effectively in clinical practice?
So, Varun, this is actually one of the most loaded questions in polymyxin strategy, where dosing has been the major cornerstone of debate for all this while. We have been still learning, and what we have learned is that uh, polymyxins are one of the most efficient workhorse antibiotics. Unfortunately, because of non-standardized dosing methodology, they have gone into a lot of disrepute, and associated nephrotoxicity, neurotoxicity has kind of made it more difficult. But as a rule, if you are able to achieve a steady state concentration of 2 milligram per liter, that is good enough to kind of achieve area under the curve, which is sufficient to have a good kill characteristic. It is actually a highly bactericidal drug, and whenever you are able to provide this dose effectively, you will have an excellent outcome. Now, to find out for the two polymyxins which are mostly used in the clinical practice, polymyxin E and polymyxin B. Polymyxin E is provided as a prodrug. The CMS, the cholesterol methane sulfonate, which is actually again converted into active moiety, that is cholesterol base activity. The dosing is actually technically 1 million unit is equal to 33 milligrams of CBA. But again, CBA is difficult to measure. What is most important is CMS, which is around 80 milligrams. So
Correct.
roughly 300 to 330 milligrams of CMS is an effective dose. And when you look at the same equivalence for polymyxin B, which is much more easier, is much more standardized, and much more effective for more bloodstream infections, where a standard regime which can be easily achieved by 2.4 milligrams of loading dose, which is actually technically around 2 million unit of loading dose, followed by 0.75 12 hourly, kind of gives you a good ballparks, good steady state concentration with effective kill characteristics. So to sum it up, if you are using colistin, you need to give 9 to 12 million unit of loading dose. And the difficulty is if you have augmented renal clearance or your kidney function is performing well, because 33% of that is going to be excreted renally.
Correct.
The concentration achievement would be difficult. Hence, loading dose is very important. And after 12 to 24 hours, the following dose would be the daily dose divided in two equal doses as an infusion over 0.5 to 1 hour as an infusion should be given. When we talk about polymyxin B, it is much more standardized. If you give a loading dose of 2 million units, followed by 0.75 million unit 12 hourly, you are able to achieve the similar steady state concentration. So polymyxin B is much more reliable on the dosing strategy. High dose, lowing dose, both with target drug monitoring has been studied, and they found that it is easily achieving the steady state concentration. While for polymyxin E, that is colistin, there could be a lot of variability, and the most important factor would be the renal clearance. So if you have augmented renal clearance, which can happen in renal failure, you may have to kind of give a little higher loading dose and maybe recheck your strategy. And for changing GFR, again you will have a lookup table, and if you are on any kind of dialysis support, you will have to really readjust your supplemental doses. Hope that
Okay.
answers the question.
Sir, one more additional question relating to this, especially in patients of augmented renal clearance, we would require support like therapeutic drug monitoring.
Right.
So, in resource limited settings like India, especially there are very few centers which have therapeutic drug monitoring practices. So, even there are no standardized colistin and polymyxin B measurement protocols.
Right.
So, have you ever tried these TDMs, or is it mainly theoretical and we are only applying their this thing in practice, not exactly the practice protocols per se?
So there is a very nice article, International Consensus Guideline on Polymyxin
Okay.
Usage in 2019 by Brian Suji and all. And they had very clearly looked at all those studies which tried to did TDM, therapeutic drug monitoring. And that is where the bulk of dosing optimization concept came in, the PKPD optimization.
Okay.
In the absence of therapeutic drug monitoring, because in our country, I don't know any place where TDM is being done. But in China, a few university centers have done that, and in West and in Europe, people have studied that. And we have data with Monte Carlo simulation, and they have shown that in those areas where TDM can be done, the effective value of steady state concentration, which is the important determinant, because if you are not able to achieve a 2 milligram per liter of steady state concentration, the effectivity of that even for good sensitive strains can go down. And that is why if you see the CLSI and UCAS guidelines have kind of changed the sensitivity pattern. They recommend that you do a broth microdilution kind of estimation of the MICs, and epidemic cutoffs are not very important, are not very relevant. So urinary isolate probably will have a different kind of MIC value as compared to a respiratory isolate.
Got it.
But the bottom line is, where you can't do TDM, you need to look for the dosing with the change in GFR for colistin. For polymyxin B, you have got a little limitation, and you can have a fixed dose strategy. And that is the most important take home. If you're using a poly B, you can use a fixed dose strategy. You don't need to make much of changes, because it is hardly 4 to 5% is renally handled. And while in
Yeah.
colistin, the majority of the thing is usually excreted out, and more the kidney is functioning, or better it is functioning, at that point more would be exited out in the urine.
Okay.
And that is why if you are using these two different molecules for different purposes, and as you know, for urinary tract infection, colistin would be the preferred drug of choice. Apart from that, everywhere else, polymyxin else would be suitable.
So the key takeaway here is, since polymyxin B is not excreted mainly by kidneys, TDM is more or less
Has not
eliminatable.
shown any great benefit.
No benefit as such, but colistin as such would require a standardized TDM practice rather than polymyxin B.
And if you look at the colistin base activity equality studies also, and that same the international consensus guideline talks about, that you can roughly take 2.5 times ratio between the two. So if you are using 10 million unit or a 12 million unit for colistin, then you are technically going down to 2.4 or 2.5 million units for polymyxin B.
Got it.
So that is one of the most important rules, that if you are giving around 10 million unit of colistin for any person with a normal renal function, you will not be exceeding 2.4 million unit of polymyxin B.
Sure.
And that loading dose has been very effective even with polymyxin B initially, which was not thought, because it's not renally handled. You can go ahead without a loading dose, but it has shown that loading dose can get the steady state concentration as early as 24 hours. While with polymyxin E, that is colistin, it can sometimes take 48 to 72 hours. And that was the major criticism against all those polymyxin based therapies, that without a standard loading dose defined, the probability of attaining a good concentration was delayed by up to 72 hours. And that was one of the reasons why heteroresistance was more common with polymyxin E, that is colistin.
That is colistin.
And this is where probably most of the people, and they have very clearly recommended that polymyxin B should be the preferred polymyxin whenever you are using, with or without a combination, depending upon the situation.
Except for urinary.
Except for urinary tract infection and CRE cystitis, where colistin has a clear advantage because of the degree of excretion.
So my next question on optimizing combination therapies, which is the most commonly asked questions these
And
days.
the controversial one.
Yeah. So what are the key considerations when deciding on combination therapy versus monotherapy with polymyxins, particularly for carbapenem resistant gram negative infections? And are there specific pathogens or patient profiles that benefit the most? My question basically means that are there specific profiles of pathogens or specific patient types in which you prefer particular combinations?
So, first of all, increasingly, there was a thought process half a decade back when we were going away from combination therapies. We wanted to have only monotherapies, and I think a lot of people have burned their fingers. All these novel BL-BLI combinations also have not shown great effectivity, especially when they are being used against an uncertain pathogen. When you are very clear about the pathogen and the genotype mechanism of resistance, it becomes much more easier to define a monotherapy. But when you are dealing with a severely hemodynamically compromised sick population, where a high incidence of carbapenem resistant enterobacteriaceae is there, or another bug like crab, carbapenem resistant acinetobacter, or Pseudomonas aeruginosa or Klebsiella. These are the three organisms, the profile that you are talking about. So CRKP, CRPA, and crabs.
Crabs.
These are the three major groups where you would be resorting to a polymyxin based therapy either as a primary therapy, as an empiric therapy, or a salvage therapy. Now, over the last 10 years, with the advent of lesser nephrotoxic drugs, we are increasingly moving away from polymyxin based therapy as empirical starting points. But it is very, very clear that if you are starting an empirical starting point without knowing your bug and only relying on BLBLI, you would be actually missing the target 40 to 50% of the time, because NDM production in our country, and I am talking about Indian subcontinent, is to the tune of 44 to 50% with or without OXA. So if you're talking about an NDM along with an OXA48, your pure reliance on any BLBLI, novel BLBLI, is not possible unless you add an NDM neutralizer like Astrin.
Astron.
So that way, if you are only talking about a combination, that's also a combinations therapy. So that combination, if you are using alone as empiric in your ICU, which all of us are doing often, with or without a gram-positive fungal cover, that is the condition where I would prefer to use polymyxin later as a salvage, as non-clinical responder, or where there is a poor microbiological clearance, or crab, because Acinetobacter baumannii, none of these combinations work well. So in crab infection, I would use polymyxin B by default as a transition, or if I have not started with it. And this is very clear take home. Again and again, it has been shown that those people who have relied on novel BLBLI combinations, after 3 to 5 days, there could be breakthrough secondary infections, which are more resistant. So coming back, today I would probably move away from empiric starting of polymyxin based therapy, unless it is in a combination, especially with respiratory syndrome. So if you have a respiratory syndrome, if you have a BSI syndrome, or if you have a complicated intra-abdominal infection syndrome, or a predominant genitourinary syndrome, in these profiles, my antibiotic choices can differ. So if I'm using a predominant respiratory, nosocomial pneumonia, which is bad, I would be starting with a novel BLBLI combination along with aerosolized, polymyxins,
Polymyxin.
which is again very reasonable to start, and vibrating mesh nebulizers, so that you have a good delivery down this, kind of alveoli, but has been shown to be very effective. There are a lot of people who are now moving away from polymyxin just for the fear of nephrotoxicity, which I can understand. But in the light of more and more resistant and unstable phenotype of patients, I would like to involve polymyxin as a combination add-on therapy. And that has always given us an advantage. And you can always de-escalate as you know your bug. If it is sensitive to lesser toxic agents, you can move on. Or otherwise, an escalation strategy. When you find that you are dealing with NDM and your response is not very good, you add on a polymyxin at that point of time.
Sir, one more question which our audience would also like to ask, I think, would be regarding the dosing of the aerosolized polymyxins. So, what is usually the dosing of both colistin and polymyxin B when it comes to the aerosolized this thing?
So, colistin aerosolized, form has been very clearly studied
Yeah.
as a single aerosolized antibiotic, also compared to IV antibiotics, where they had used 12 million unit. That is 3 million unit 3 times a day as nebulization. 9 to 12 units, 12 million units in a day. But that study was again not very well taken, because it was a single aerosolized antibiotic
This
for a
this was, I
pneumonia.
think, a recent NEJM
Correct.
publication.
And they said that probably it is best to add on aerosolized along with IV, colistin therapy. So you
Okay.
give IV colistin and add
And
another
a
3 million unit, 1
supportive.
million unit as aerosolized, so that your epithelial lining fluid concentration is appropriate. And that is probably the best strategy. And we have in our practice used polymyxin B as IV and aerosolized colistin as the add-on inhalational
Okay.
drug, and which has worked very well for most of our.
Because the protocol for polymyxin B aerosolized is not that well
Not
defined.
very clear, not very clear. And the most important thing is that you need to use that aeroneb, something which is kind of giving you a vibrating mesh nebulizer, not the conventional nebulizer, because the drug doesn't get deposited into the alveoli. And that's the biggest mistake. Most of the places don't have that small molecule, what is called atomization, So the drug gets mostly concentrated and causes more bronchospasm. And then the therapy
Okay.
gets a bad name. So Aerogen has a very nice vibrating mesh nebulizer which you can use. The drug is very finely dispersed and it can reach down as low as the alveolus.
Alveoli.
And that is one of the most important way. Otherwise, most of the time people get bronchospasm. And there is another strategy where people have used beta 2 agonist followed by a colistin nebulization, so that the
So
drug
that
deposition is
the
very good.
bronchodilation is there
Absolutely.
and
And the drug reaches there. And I may be sitting from here talking as an expert. This is my personal opinion. For crab pneumonias, I have not seen better results with any other regime
okay.
where you don't have a aerosolized inhaled
In
colistin
inhaled
added to it.
colistin added with IV poly-B.
Absolutely, absolutely. That is
Okay.
something which I will rely. And Acinetobacter, anyways, is much more difficult organism to treat with the conventional novel BL-BI combinations.
Okay. So my
Unless sulbactam, durlobactam that people are talking about, or ampicillin sulbactam, or
okay.
high dose sulbactam is also one of the options that people use. So either high dose sulbactam along with polymyxin and aerosolized colistin would be one of the best standard ways to tackle with this kind of difficult infection.
So my next question, sir, is about the management of minimizing nephrotoxicity with polybs. What are the most effective strategies to mitigate nephrotoxicity associated with polymyxins, and how do factors like fluid management, alternative dosing regimens, and concurrent nephrotoxic agents influence renal outcomes?
Actually, this is the most important aspect because sepsis-induced nephrotoxicity is more prevalent than drug-induced nephrotoxicity that we talk about. But we cannot run away from the fact that conventional colistin has been associated with nearly 33% of nephrotoxicity in clear-cut studies, and that is one of the basic weakness for which colistin has taken a kind of side role today in the management of difficult to treat gram-negative infections. But having said that, knowing it very clearly that if you are using it in a renally challenged patient with colistin, you will need to be very, very cautious about the dose that you provide because the colistin drug accumulation is very high. While with polymyxin B, the drug accumulation risk is much lesser. And hence, the comparative analysis has said that 33% of nephrotoxicity can go down to 13 to 14% nephrotoxicity with polymyxin B usage, and you don't need to really bother about the dosing because it's hardly renally kind of handled. While using of colloidal suspension, which is the newer technology that we have been using for last half a decade now, has shown that the megalin induced colistin
Uptake.
polymyxin B uptake can be reduced, and that can have a significant effect and in reducing the polymyxin accumulation in the body and the toxicity because of that. So I would very strongly suggest the renal guard technology, the Polymyxin that we have used with polymyxin B in all those patients which are having high likelihood of worsening renal function, or any person who has a high likelihood of AKI,
Yeah.
starting creatinine which is high, or the volume of distribution which is very, very high, where again the dosing needs to be optimized. So difficult to treat patients where PK/PD optimization is required. Reduction of nephrotoxicity would be obviously based upon other parameters, the fluid resuscitation, optimal fluid resuscitation, looking at cumulative positive balance, which is one of the most important part, and early initiation of renal replacement therapies. In fact, majority of the times people are not looking at the reducing, dwindling muscle mass and a static creatinine as a clear-cut indicator of falling GFR, but people don't look at dynamic GFR. The creatinine is same, but the muscle mass is going down, water accumulation is happening, volume of distribution is high, and we are blaming the drug for the nephrotoxicity rather than the AKI dynamics. So I would very strongly suggest that early initiation of the basic precaution bundles for AKI should be looked at.
Okay.
Remove all the nephrotoxic agents as early as possible, optimize fluid balance, look at the cumulative fluid balance, look at solute and solvent discrepancies, and early initiation of renal support. And in that situation, I always feel very comfortable whenever we have early initiation of RRT because we can go down with the full dose and hammer and tongs approach with polymyxins. In fact, that is one of the ways if you are very difficult to treat patient who is renally challenged on renal support, intermittent or continuous, you can actually feel very comfortable with your polymyxin dosing. And that's probably one of the most important points. Rather than running away from polymyxin at that point, we should actually incorporate that into a rescue antibiotic strategy.
Okay. So my next question is about polymyxin usage in critically ill patients. It is more or less a reiteration of my first question, which you dwelled very much into depth about therapeutic drug monitoring and everything, about personalized medication. So given the altered pharmacokinetics in physically critically ill patients, example augmented renal clearance, sepsis-induced changes, what practical dosing modification should be considered to ensure optimal efficacy?
So the future is TDM, and I would very strongly urge the industry to get the TDM available at the bedside. Because if we are able to get the steady state concentration very clearly measured, even the CLSI and UCAST breakpoint which have been kind of changed, the intermediate sensitivity which has been put is basically because of inability to attain that kind of concentration effectively without breaching the therapeutic dose recommended. And then everybody starts walking on eggshells, that you have a creatinine which has just moved from zero point 0.9 to 1.5, and the patient is actually having a severe hypotension, and is anyways gonna go into the AKI trajectory. At this point of time, you know that it is infection associated, and there you are kind of limiting your role and choosing a safer option just because it is nephrosafe. Now that's a very defensive medicine. Rather than being able to kind of use something which is very clearly defined by therapeutic drug monitoring, it would have been very easier. So if you can provide polymyxin TDMs at the bedside, I think that will be great service. Aminoglycosides are available. Isavuconazole has already come down. A lot of new drug, vancomycin was always there.
Yeah.
So I don't see any reason why this should also not come in. There are a lot of standardization problems, but that should be done. At least for one of those most commonly used, polymyxin B should be available, which can give a benchmarking for those clinicians who are dealing with sick patients where limited therapeutic options are there. In CRAB, CRPA, difficult to treat pseudomonas, and Klebsiellas to some extent will be the three areas where if there is NDM production, you will need to have polymyxin based strategy as a combination therapy. And most of the time, most of us are choosing still redundant antibiotics because there are no other option.
Yeah.
We give ultra high dose of carbapenems in various dosing, or some BLBLI, and with astronam coming in. My biggest concern is that as the more and more resistance profile comes in, we'll have no more options, and where polymyxin would be made to sit on the bench just because we are worried about its usage and nephrotoxic potential. So I don't think we should get polymyxin completely out of our clinical thinking, because up to 5 or 7 years back, polymyxin was the major workhorse antibiotic for all our difficult to treat antibiotics. We should not so quickly wean away from that. Okay. And coming back to dosing strategy, one simple rule: if you are doing dialysis, sled dialysis, for every 1 hour, 10% of the dose should be given. So if you have 6 hours of sled planned, then 60% of the daily dose should be given post dialysis. So
Okay.
that is a simple rule of thumb. 10% per hour of the sled. That is a daily dose that should be given.
Okay. Addressing resistance and stewardship practices. With the rise of microbial mediated colistin resistance, what are the key antimicrobial stewardship strategies that critical care physicians should adopt to preserve polymyxin efficacy and prevent further resistance development?
So the key is again a good intensive care practice where you try to know the bug, know the host, know the drug. All the three things have to be done. You must know what drug you are using. You must know what host you are, kind of host factors you are looking. And lastly, what is more important is you must know the bug. And knowing the bug is not about just getting a culture these days. You have those rapid diagnostic tools, which I call as diagnostic stewardship practices, which are more important. You need to identify the resistance potential and the mechanism early on. So rather than just knowing that the bacteria is present, it is more important to know that we are dealing with a bacteria which is producing NDM and OXA co-production.
Okay.
And that itself, or a WIM production. So that itself kind of alerts you, looking at your hemodynamic profile of the patient, whether I can kind of have a step-up approach or go up with a completely escalated module. So if I know that I have got an NDM OXA48 producer, Acinetobacter or a Pseudomonas, there my dosing strategy will not be passive. I'll go more aggressive. I'll be thinking of starting a better microbiological control with a polymyxin based strategy if necessary, especially for pneumonias and UTIs. These two areas where polymyxin has shown to be very, very effective should be started on.
Okay.
And later on, looking at the final culture report, you can kind of choose your antibiotic optimization.
Now, revisiting the breakpoints and susceptibility testing related strategies, How should clinicians interpret the MIC breakpoints for polymyxins, and what are the challenges in reliably determining susceptibility in clinical microbiological labs? And how do these factors impact treatment decisions?
This is actually the most difficult part.
Yeah.
As a treating clinician, I would say I would be out of my comfort zone if I start talking on that. But a lot of research has been done. CLSI and UCAST have very clearly defined and said that you can only say that they are intermediate sensitivity, because this is the new recommendation that you only talk about intermediate sensitivity for most of the polymyxins for the strains, because they are all extrapolated data. And but it has been very clearly shown that the incidence, because MCR gene mediated resistance is the only way that cholesterol
Yes.
resistance can come in, which still to date in the maximally reported has been 10% in certain areas, otherwise less than 1 to 2%. In our country, most of the data has shown that 1 to 2% is the MCR gene mediated cholesterol resistance. So barring that, cholesterol sensitivity can be very easily taken for granted for most of the tough, difficult to treat organisms. If you are still worried about, you can look for the MCR gene. There are a lot of, kind of uh, newer modules which are kind of able to give you all these genes, including all the WIM and the OXA48, NDM, and MCR gene as well. The BioFar also has probably in their, bone and joint as well as the bloodstream panel where MCR gene is also being checked. But I would suggest that whenever you are using polymyxin, I'm more worried about the dosing rather than it is sensitivity, because I have barely come into my clinical practice that resistance, kind of phenotype to colistin yet. But I'm sure in all those places where it is being overused, probably that would also be seen often. There
Okay.
are Indian data from down south where 3 to 5% of colistin resistance has been reported, but that is mostly into certain specialized bugs, not in our
But
usual
that would be the
Klebsiella.
highest. 3 to 5 would be the highest.
I would suggest that. I would probably not be, it won't be fair on my part to say that I know it, but you should speak to clinical microbiologists. And as far as I have connected with them, they agree with this number,
Okay.
that the incidence is very low. In our own studies of our institution, we have checked for that. We have hardly encountered cholesterol
Okay.
resistance. I must tell you that. So that is for our institutional practice, and we are at a super specialty hospital where we have a high CRE rates. We have 80% of carbapenem resistance in certain pockets of Pseudomonas, Acinetobacter, and Klebsiella. And there, when you are comparing colistin resistance, that data is hardly any.
Okay.
So that gives us reassurance, but also adds a lot of burden of responsibility to the clinician, that when you are using it, you don't use as monotherapy. Monotherapy I would not recommend. A combination strategy should always be used. The next most susceptible or best MIC profile agent should be used. If not, even a carbapenem can be used, and that has shown to be very effective. So that combination strategy gives us more confidence of using, for example, let's say tigecycline along with polymyxin. Now that gives me more confidence when I am dealing with an intra-abdominal infection with
Yes.
polymicrobial growth, rather than relying on a BLBLI along with astronam and nothing else, because that would be something which I would not prefer. And that anyways, a lot of clinicians who have studied BLBLI along with astronam as a starting point have not been comfortable with intra-abdominal or respiratory infections, not adding another drug. So when you are adding another drug, at that point of time, I would be more happy having my workhorse antibiotic as polymyxin. In
Okay.
those difficult to treat infection, obviously my host factors should also be considered.
Okay.
Hemodynamically unstable patient and somebody who has bad respiratory infection with bad PF ratio, clinically not looking good, I don't think I will have chance to escalate it later. I'll
Okay.
start with this first one.
Okay. So my last question for this session is regarding the future of polymyxin therapies. So what are the most promising advancements in polymyxin research, such as novel formulations like Polymyxin and prodrugs or next generation polymyxins, and how might these developments influence critical care antimicrobial strategies in the near future?
I think it is exciting because for last couple of years that we have been using Polymyxin, and this is now we don't have any data, organized data to back up, but it is mostly expert guidance, personal opinion. We have not really worried about nephrotoxicity. Believe me, I have a person whom we have used over. This is a polytrauma patient who had gone and seropositive, who had multiple rounds of resistant infections. We have used at least 3 times in the same patient. Polymyxin B, specifically Polymyxin. Once though they were not able to get Polymyxin, he has been on intermittent CRRT. That means he was on CRRT for 3 to 4 days, and his kidney function recovers back, and he comes out. And his kidney function, mind you, was not directly related to the usage of Polymyxin, but by the hemodynamic instability. Every time he will go hemodynamic unstable, his creat will slightly go up, and we would be proactive to start an RRT.
Okay.
And we were not just imagining that this gentleman will hold on, has severe immunocompromised status to start with, multiple infections, osteomyelitis which we were treating with multiple antibiotics, and in that when we were using polymyxin for Klebsiella infection which he had developed, we had seen good microbiological clearance from bloodstream. So I would very heavily rely on a polymyxin based strategy in a very difficult to treat patient. If the future allows us to have TDM,
Yeah.
it would be very important because we can have a robust number to kind of ballpark our therapy around, and that will be very, very important advancement which will take away the guesswork out of polymyxin therapies. In fact, we all know that vancomycin is toxic, aminoglycosides are toxic, but they are very effective. And how do we kind of use them? By getting TDM. So if we are getting TDM for polymyxins, I think that will give again a lot of confidence to the clinicians to use it, because majority of the what is called the disrepute that polymyxins have got recently is because of their nephrotoxic potential. Everybody agrees in its efficiency, and they have seen even in the largest meta-analysis that 74 to 75% success rate was there with polymyxin based strategy, and they have compared with best alternative therapies. The only thing that they said that there was a definite increase of 26% nephrotoxic potential. So I agree, if we are able to target it better, and none of them have, or hardly few of them used TDM. So that shows that if you have TDM based therapy monitoring, yes, it needs to kind of compete with newer BL-BLI combinations and newer future generations which are
Yeah.
coming in. So we'll have to see how polymyxins adapt with that. And having a renal guard technology like Polymyxin, which I personally feel is a major breakthrough because it has a clear-cut science behind it. Megalin-based reabsorption is kind of slowed down, the molecule becomes big and has different charge which doesn't allow it to easily get a tubular reabsorption and accumulation of polymyxins. Can be a very important way. I don't know how we can do it because colistin is actually in a prodrug formulation. So it will be difficult because there probably this technology may not help.
Yeah.
But at least in polymyxin B, this definitely gives us a lot of confidence using it parenterally for bloodstream infections, for respiratory infections, barring renal infections or urinary tract infection, I would say. We can use it as a safe workhorse drug or an accompanying drug in combination strategies for sick patients, if I can conclude.
Okay. So, very well put, sir. Lastly, I would like to ask the audience if they have any questions.
So I just wanted to ask what all combinations are using with polymyxin?
So-
Like polymyxin plus tetracycline or carbapenem with polymyxin, and what is used in zanicycline and poly as well.
So Xavi with poly has been used a lot. We have used a lot. In fact, one of the small studies that I reviewed, which was by Dr. Vasant Nagvekar and all, they have used BLBLI, Xavi combination along with polymyxin in 33% of their cases, and another few tigecycline and phosphomycin. So if you ask me, even in novel BLBLI combinations for NDM producers or NDM OXA48 co-producers, people want to go ahead with one more additional drug. So only 33% of them had this, not even monotherapy, a combination strategy of only Xavi with Astronam. 33% of all those post-transplant infections that they have spoken about, 111 patients. And one more study was there from South, I'm not able to recall, where again various combinations were used with even Xavi Astronam. So it is very unfair to say that that is a kind of a real answer to all our resistant infections, because it depends upon syndromic approach. So what are we dealing with? How sick is our patient? Similarly with polymyxins, always whenever we were using polymyxin previously, we would use carbapenems because we would not encounter MICs of more than 32 very often. Now 16, 32, 64 very easily seen all across the page. So I don't think carbapenems would be a great additional drug. But I would rather here play around with either cyclines like tigecycline or minocycline for Acinetobacter. For Pseudomonas, I may again think about getting a different Zyviceptor-Aztreonam combination if there was some synergy present. Or sometimes ceftriaxone tazobactam can be also used if that is available, which is also available in grey market. And for Klebsiella, that is the only place where polymyxin usage may be restricted, because we have excellent kind of combinations there which work for Klebsiella. Even cefiderocol has done very well. So you will probably have to look for crab infections as one of the indication where I would like to incorporate polymyxin based strategy. Apart from that, Pseudomonas, difficult to treat DTR Pseudomonas, where again I will rely on this as an add-on drug, either with Zyviceptor-Aztreonam or the workhorse with something else. And depending upon intra-abdominal infection, again for better reach, along with a cyclin, probably would be a good choice. So this is how you would probably kind of do. For long-term usage, there will be a problem. So beyond 14 to 21 days, using this would be very difficult, because I dread more neurotoxicity than nephrotoxicity, because that is something which is very easily visible. I feel neurotoxicity is underreported or under recognized most of the time. Critical illness neuromyopathy can also kind of come up with this, and that is where probably polymyxin has another rate limiting point. But it is usually manageable, because most of the time when the infection gets better, most of the time our neurological implications also get better. So you can call it as a target organ damage or an add-on kind of neurotoxicity with polymyxins.
When you're using polyplus tigecycline, are you seeing any, we are worried about the USA, it comes with the black box.
So bloodstream infections using would not be really advisable. For intra-abdominal infections and chest infections, it can really work well. And abdominal, obviously you can use it. Bloodstream infection, you should use it with caution. But again, I will counter that. When you're using polymyxin, I don't think you should be worried on that, because it should not be used as a monotherapy for BSI. That's very clear. So you don't use tigecycline as a monotherapy for BSI, that's contraindication. If you are using along with colistin, I don't think there is any harm, because you have two different mechanisms of working, and there is a sidal drug along, and you are reducing the resistance potential and probably synergistic action. So that is the only in fact, I would use a polymyxin based strategy for tigecycline if I have to ever use for a BSI along with organ infection. So sometimes you have abdominal infection with bloodstream also growing the same bacteria, and you want to use tigecycline, but you are worried about BSI now. That is the point where you use polymyxin therapy.
So any other question from the audience?
What are the ideal conditions to use antibiotics in negative group? Like cholesterol?
Pneumonia, I am a very strong user. A lot of people don't like that, but I personally feel the only thing is the drug delivery has to be up to date. So I use, in fact, tobramycin also, and that has been for ages shown in cystic fibrosis as the way of choice. And even with resistance, you can use it for long term, and you can actually put away the pressure from other drugs that you normally needlessly give, and they usually don't, because they are stable patients. They are not worsening. Now, an unstable patient who has got a bad bug in the lungs, any drug strategy has been shown to have limitations. People have, in fact, one of the studies of imipenem, cilastatin combination failed miserably when they used it as a monotherapy against, carbapenem with a combination therapy for long term. They gave it only for 7 days monotherapy, thinking that it was supreme, and it didn't work out. The same way, whenever you are using for a chest infection, especially for a nosocomial pneumonia, I would always prefer to add an aerosolized component to a parenteral component. I use 1 to 2 million unit 8 hourly with aerogen nebulization, which can deliver it well, with an accompanying drug which has the best sensitivity profile. Even if it is a BLBLI, that is fine. And that add-on, I cannot quantify how it works, but we have seen, and honestly I say, our patients die with bacteria not due to those bacteria. That is for sure. But they don't die because of the pneumonia. They die with a pneumonia, that's a different issue, because they have other issues which are coming in. Lot of other things, and it is well treated. Very often when the patient's gas exchange is worsening, your clinical profile is not improving, you can completely agree that your drug is not functioning, and there you can use the third drug. You can use another. So triple therapy can be reserved for those situations. Most of the time, you may have a kind of pulmonary empyema, which is probably not allowing the drug to also reach at that site. And there are, kind of non-infectious mimics also sometimes. So pneumonia is the only syndrome where I would definitely use an aerosolized form as an add-on, not as a sole therapy. Those people have done that 12 million unit nebulized. I don't think that is a great strategy. It can also increase a lot of resistance and probably selection of different bugs. I don't think that's a great strategy. But using aerosolized, I'm a very pro for that. But you should always use a vibrating mesh nebulizer. A normal nebulizer is the reason why the therapy fails.
Can we give fungicides to renal infections?
Cranial infections?
Renal, kidney infections. Like some are using, but I heard that there is
UTI, no. A hematogenous pyelonephritis, add-on drug, you can use it. So if you have a metastatic infection with renal abscesses, no. Monotherapy definitely no, because see, the same logic when you have bloodstream infection, the idea is that you need to have a sidal concentration. While this drug's PKPD kinetics is so that it will never reach that kind of concentration alone. And that is the whole point, though it may be effective. And that's why on therapy resistance will be very, very high. And this is a black box warning all about, that you cannot use it for those drugs which have either high flow or bloodstream infection, like endocarditis. You can't even think of that. Even with a sensitive drug, you can't think of that. The dosing strategy is not so. Same way with high flow to kidneys, pyelonephritis, using it alone, not a great strategy. But using it along with a combination probably can be justified. Still, you should think twice and talk to your ID specialist or a microbiologist. That's what I say. Don't be a lone warrior. Don't be an ID consultant, or don't be a critical care specialist with a lone warrior, trying to fight all the battles, difficult to treat infections on your own. I think that is where, and most of the ID specialists have moved away from polymyxin, as I see these days, because they are all worried about nephrotoxicity. But most of the clinicians and intensivists, they still see the response. That's why they don't want to go away from that, because the dramatic change is very, very obvious. So I personally feel that's why a colistin or a polymyxin B based therapy will be important for severe infections and in highly critically ill patients. And CRRT is something, or a SLED, where actually you should be more emboldened to use that, in my opinion, rather than being worried. Because if you have already considered it, no shying away from that, in my opinion.
Thank you, sir, for the insightful discussion and your to keep the session very interesting. And thank you for the audience for your interesting queries.